99.99% of these cases unites without any significant deformity, without any significant functional impairment. But later on, it was found that there are severely displaced fractures, severely comminuted fractures. About 15% of cases require surgical treatment, either in the form of tense nailing or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is tense nailing. Unlike conservative management, it provides stable fixation and early mobilization and reduce the risk of non-union and malunion. Tense is less invasive, resulting in a smaller incision, reduced soft tissue damage, and fewer potential complications, making it an attractive option for managing displaced fracture of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, all were simple displaced fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nailing in my hospital. So the mode of trauma, no traffic accident was the main mode of the trauma, whereas fall from height and fall on out-stretched hand was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI. And this is a typical clinical presentation, a bump at the site of the fracture, and the skin appears as if the fragment will penetrate the skin. And this is the radiological typical presentation, more than 2.5 centimeter displacement, and the jet type of cognition are the radiological indication for the surgical treatment, either in the form of tense or internal fixation with the plate and a screw. So these are the already explained. The simple fracture were taken into consideration. Displaced simple fractures, either spiral or oblique or transverse or short oblique, 15D1 and D2. The patient lies supine if we are affected lip, elevated, and the arm are hanging outside the table, so that we can facilitate the abduction and external rotation at the shoulder to facilitate the abduction of the fracture by closed wing. The incision, a small incision, has a transverse or longitudinal incision about 1 to 1.5 centimeters, just lighter to the sternoclavicular joint is given, and after making an incision, we make a hole with the help of drill bit, and then we make this hole continuous with the intramedullary canal of the clavicle. But this is very, very crucial step. One should take his own time and use tips and tricks to do this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense nailing after close reduction or mini incision reduction. So the immediate post of pain management and immobilization, at the 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, and 12 weeks the functional assessment, and if required, the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bifurcation, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the few cases. You can see that 15B1 fracture treated by titanium elastic nailing, beautiful surgery without use of any instrument. The reduction has been done only by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery. And this is another case, yet another case of the 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B1 fracture treated by titanium elastic nailing. These are the 15B2 fracture. This is 15B3 fracture treated by titanium elastic nailing. Ideally, it should be treated by open reduction and internal fixation, but we did tense nailing, and you can see that 6-month follow-up. the beautiful radiological union. And this is the functional result. You can see. So the time is less. So the limitation of this surgery is a small number of cases included in this case, in this study. So the short follow-up period and retrospective design. So a study with large number of population and long duration of follow-up and prospective study is required to establish this modality of treatment as an attractive option for the treatment of displaced fracture of the take-home message is tense scaling is effective for the clinical fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further studies are needed to confirm the long-term efficacy of this. This work published in International Journal of Orthopedic Science.
जिसके पास रिक्शा करके जाने के पैसे नहीं होते थे, आज वो अपनी फैमिली को अपनी कार में 5-स्टार होटल ले जा रही थी।
17 years old man, the road traffic accident was the mechanism of injury, clinical presentation, severe pain and deformity, and inability to bear the weight on the right side, whereas the left side he had a gallery fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex forearm fracture and dislocation, which is called the gallery fracture and dislocation. And this is the X-ray of the femur, the shaft femur, mid-third fracture of a 17-year-old gentleman, and the forearm gallery fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing. And ideal treatment for this gallery fracture is the plating, but I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for gallery fracture, and this is not reported in any literature for such a severely displaced fracture. The tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of gallery fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the shaft femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail and technique was minimally invasive, and whereas in this left radius, the gallery fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use a 2.5 millimeter tense nail, but we use 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is a 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for gallery fracture. So, but I left it and wait for, this is the 8-month follow-up. Still there was better union than 6 months hypertrophic. But this was not hypertrophic, and this is 11 months. You can see. So after waiting 11 months, the union is complete in both the fracture. The secondary colors have been formed. It was not hypertrophic non-union. It was the union, secondary union was taking place, although it was delayed union. But this is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension all are present. And the tense swelling is provides sufficient stability for secondary union even in length critical fractures because the narrow canal and the length should be maintained to and DR UJ should be reduced properly. We followed the throughout 11 months for this maintenance of the length and DR maintenance. And advantages of this minimally invasive approach for Gallagher fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirmed that interlocking nailing of femur and TENS yields higher union rates and excellent functional outcomes. This approach should be considered for Gallagher fracture in adult after further studies, because I think this is the first case in severe Gallagher fracture. I did TENS. So this case was published in International Journal of Orthopedic Sciences.
I'm just lazy. What is actually happening is your brain is protecting you from perceived threats. I lack discipline. What is actually happening is your subconscious mind is running on survival mode. I'm not smart enough. What is actually happening is you have limiting beliefs from childhood experiences. Success is not for me. What is actually happening is your identity is programmed for your current reality. Myth number 1, you are thinking, I'm just lazy and that is why I can't achieve my goals. The fact is that your brain is protecting you from perceived threats. Every time you try to take action, your subconscious sees it as dangerous because past experiences linked effort with criticism, failure, or pain. So it creates resistance to keep you safe. Myth number 2, you are thinking, I lack discipline and willpower. But the fact that our subconscious is running on survival mode and now no amount of willpower can help you overcome subconscious programming. You don't need more discipline. You need to reprogram the system. Myth number 3, you are thinking, I'm not smart enough. But what is actually happening is you have limiting beliefs from childhood experiences. When you were told you are not good at this or why can't you be like them, your brain absorbed these as facts. Now these beliefs run automatically, creating self-fulfilling prophecies. Myth number 4, you are thinking success is not meant for me. But your identity is programmed for your current reality. Your subconscious mind works to keep you consistent with who you believe you are. If your identity is I am someone who struggles, your brain will sabotage success to maintain that identity. But the good news is, all of this can be reprogrammed using the RRR technique in my Ultimate Success Builder workshop. In this workshop, you will learn how to identify the real cause behind your procrastination, the exact technique to reprogram limiting beliefs at the subconscious level, how to rewrite your identity to match the success you desire. So if you are ready to understand what is really happening and fix it at the root level, then click the link below and register for the Ultimate Success Builder workshop now.
Provides stable fixation and earlier mobilization and reduces the risk of non-union and malunion. Hence is less invasive, resulting in smaller incision. Conducted a study between March 2020 to March 2025 on 25 cases of the displaced fracture of the clavicle. The age of the patient was 16 to 48 years and no comorbidity was found in our study group. All patients treated with titanium elastic nailing. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on the outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in mode of trauma. And this is the typical presentation, a bump at the fracture site, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So, and this is the typical radiological picture. You can see the severely displaced fracture, more than 2.5 centimeter, a jet type of fracture, that type of communicated fracture, and the other indication for surgical treatment is the floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to AO classification. 15B1 is a spiral and oblique, whereas 15B2 is the transverse and short fracture. So the patient lies supine with affected limb elevated and hanging outside the table so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision, there is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone out. But this is a crucial step. One should be very, very cautious because the heart and the lungs are like vital structures are waiting for your instruments to escape. So this is the very crucial step. And then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic nailing was done after reduction of the fracture. So the post-op protocol or immediate post-op, we did pain management and immobilization of the limb at the 2 weeks, the wound inspection and the suture removal at the 6 weeks, the radiological follow-up for the fracture healing, and by 12 weeks, the functional assessment of the fracture healing, and finally, if required, the implant was removed at the 12 weeks. The 6-month final follow-up was the 20 to 50 ml in all our cases. So the post-operative observation, excellent results, 76% of patients, whereas the good results were found in 16% of cases, whereas the 4% was the figure for the fair as well as the poor results. So the complications, the nail bite out, superficial infection, and malunion each had 4% figure, and the hardware irritation was 8% in all our cases. These are few cases. The radiological as well as clinical picture, as you can see, this is 15B1 fracture, treated by titanium elastic nail, the post-operative case, and the beautiful surgery has been done. You can see the 1ST surgery, no instrument was used to reduce the fracture, only the thumb and the index finger was used to reduce the fracture, and abduction and external rotation of the shoulder was used to reduce the fracture. But this does not happen always. Many times we require the mini open reduction of the fracture. So this is another case we did, the 15B1 fracture treated by titanium elastic nailing. You can see the 6-month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site there is secondary callus formation. One bump is due to secondary callus formation, and other at the entry site, you can see that there is hardware prominence. So this is another case of the mid-third fracture treated by titanium elastic nailing. Yet another case, 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B2 fracture treated by titanium elastic nailing. And this is again 15B2 fracture treated by titanium elastic nailing. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with the plate and screw, but we did titanium elastic nailing in this case also, and you can see that the beautiful union of the fractures at the 6 month follow-up period. So this is the functional result. And the limitation of this surgery, a number of cases included in this study was small and the short period of follow-up, and this is the retrospective duration, and a prospective study is required to establish this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS nailing is effective for the clavicle fracture with good to excellent results, the minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here.
At GoDaddy, we know your website is the center of your online business. Help protect it from online threats with website security. Every GoDaddy plan comes with an SSL certificate that will protect your customers' sensitive data, along with daily malware scans and a firewall, all of which you can manage from one place. A protected site will also help your search ranking. Get peace of mind for your online business today with GoDaddy.
ट्रिंग ट्रिंग।
हेलो,
मैं तुम्हारे पापा के बचपन का दोस्त चतुर चाचा।
पहनाव चाहता है?
उनसे बेटे 5,000 लिए थे, अभी तुम्हें ट्रांसफर किया है बेटे, और गलती से 50 चले गए। पेमेंट मैसेज चेक कर लो बेटे और बाकी 45 मुझे लौटा दो।
आपका मैसेज बाद में, पहले अपना बैंक अकाउंट चेक कर लो। मूर्ख ना हूँ मैं।
यूपीआई कहता है कोई नकली पेमेंट का मैसेज भेजकर पैसे वापस मांगे तो उसे कहो मैं मूर्ख नहीं। जाइए आप भी किसी का टेस्ट लीजिए।
ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापेटलर नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैलिएबल गाइड वायर को सीआर के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद नेल को गाइड वायर के सहारे सीआर के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। एक उचित साइज के नेल को सेलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है और अब
नेल को डाला जा रहा है। अब नेल को फाइनली लोअर एंड ऑफ द मेडुलरी कनाल तक डालने के बाद उसे अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है RCT नेल इंट्रोड्यूसर कंपोजिशनर, जिसके द्वारा नेल को डाला गया है। अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से सी आर्म की मदद से गोल करने के बाद, होल को गोल करने के बाद इस तरह से सी आर्म को एडजस्ट किया जाता है कि होल गोल दिखे, और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल, और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है, स्क्रू डाला जा रहा है। अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है। फाइनली दोनों स्क्रू को, उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है नेल को, और अब लोअर फ्रैगमेंट के एंट्रोपोस्टेरियर जो होल है उसको गोल किया गया है। इस तरह से सी आर्म को एडजस्ट किया जाता है कि वो गोल दिखे, और एंट्रोपोस्टेरियर स्क्रू को डाल दिया गया है, जैसा कि आप पिक्चर में देख सकते हैं। और देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है। इस तरह से सी आर्म एडजस्ट किया गया है, और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है, और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू लोअर फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए, छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में। और ये फ्रैगमेंट फ्रैक्चर है, आप देख सकते हैं कितना बढ़िया रिडक्शन हुआ है। 3 भाग में टूटा हुआ था। ये 3 लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है। ये RCT नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला।
Hello friends, today I am going to give a demo of interlocking nailing in fractured shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the sharp femur. As you can see, in the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the sharp femur. So this time the patient had come to me for the lower third fracture of the sharp femur or other limb. So let us come to the surgery. First of all, I will make an incision just above the greater trochanter, about 2 to 2.5 centimeters diameter, and then after blood dissection of the tissues, I am introducing a bone out just medial to the greater trochanter in the piriform fossa in AP view. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am having the bone out inside the intramedullary canal so that it can enter in selected exact entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture, and epi view, this is the lateral view, this is the epi view, and this is the lateral view. Again, I have focused to confirm the entry point. And finally, after confirming in the CR picture the correct entry point, I am introducing by a screen movement of the CR, and you can see that this is the every view, it has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior 2/3 at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. So after confirming it, I am going to introduce still I am introducing the bone out inside the intramedullary canal, and finally a 2.5 millimeter guide wire is being introduced inside the intramedullary canal, just lateral to the bone out, which has been pulled out to make an space in the lateral part of the bone out to introduce the guide wire. And finally, after introducing the guide wire, we removed this bone out, and then after reduction of the fracture, with the help of the F tools, my assistant is holding this fracture in proper position, and the guide wire has been introduced in the distal fragment. And after introduction of the guideline, we are going to read the medullary canal with the help of 9 mm reamer, and it is being rimmed with 9 mm reamer, hand reamer, and it has crossed the fracture, and my assistant is keeping the fracture in reduced position throughout the nailing process with the help of the F tool. During nailing process also, it is kept in reduced position, otherwise there may be malalignment of the fracture. And I am doing reading with a 10 mm reamer, and still my assistant is keeping the fracture in reduced position, and I am confirming on the CR whether the fracture is in reduced position or not. And this is in reduced position, the slightly distracted, but in reduced position, in amplitude, and also in lateral view. This is the oblique view. And also performing in the CR in both views. We did reading up to the lower range of the femur, and finally we removed this fracture with the help of power remote 11 mm. Because the patient is old one, so reading is easy. It is just to measure the size of the intramedullary canal, the diameter of the intramedullary canal, so what size of the nail should be introduced so that it can fit in the intramedullary canal. The fitting nail can be introduced. So this is the purpose of reading, because the patient is more osteoporotic throughout the healing process, reading process, and keeping the fracture in reduced position with the help of my assistant, so that the malalignment can be prevented. And finally, I have introduced the tightening the screw, the second screw in the proximal fragment. As you can see in the CR picture, the proper size screw has been tightened in proper position. But it was accepted because the effect of anesthesia was wearing off. So it was accepted. And you can see that both in the FT and lateral view, the both proximal as well as the distal